تكملة للمحاضرة مالت imaging of pancreatic tumors is imaging of the pancreatic neoplasm. المين topics اللي راح ناخذها اليوم هي Ductal Adenocarcinoma, Cystic Neoplasm, and the Neuroendocrine tumors. Ductal Adenocarcinoma, it represents 2 to 3% of all cancers, 90 to 95% of all pancreatic neoplasm. A risk factor for developing of pancreatic ductal adenocarcinoma is smoking, alcohol, and chronic pancreatitis. It has a very poor prognosis with high morbidity, and only 10 to 20% are surgically resectable at time of diagnosis. The overall 5 survival rate is about 5%. The tumor marker, cancer antigen 19-9, is associated with pancreatic cancer, but it is neither specific nor sensitive for the screening or the diagnosis. نقدر نستخدمه بالfollow-up of the patient after the surgical resection. إذا رجع صعد معناها إنه marker for potential disease progression. The presentation عادة ما يجي the presentation as a weight loss, anorexia, and abdominal pain. The tumors arising in the pancreatic head may obstruct the common bile duct, resulting in obstructive jaundice. It might present with painless jaundice with a large gallbladder, اللي نسميها couvre-feu gallbladder, or might present as Taghasso syndrome, اللي هي migratory thrombophlebitis. ممكن تجي presentation as a lipase hypersecretion syndrome in 10 to 15% of cases, اللي هي polyarthralgia with subcutaneous fat necrosis plus minus lytic bone lesion with elevated serum lipase and eosinophilia. The most common site for the that can occur is the head of the pancreas in 75% of the cases, and in minority of the cases ممكن نشوفها بالbody 15% and the tail of the pancreas 10%. At the time of the diagnosis, the pancreatic head carcinoma عادة تكون أكثر من 3 سنتيم, and when a tumor of the pancreatic body and tail are diagnosed عادة تكون large size لأنه تجي as a later presentation. الtumors بالpancreatic at the area of the pancreatic head ممكن involve the periampullary tumors اللي ممكن تشمل pancreatic ductal adenocarcinoma involving head and uncinate process, or lower common bile duct tumors اللي هي cholangiocarcinoma, or ampullary tumor arising from the ampulla of water itself, or polyampullary duodenal carcinoma. The best imaging modality for the diagnosis of pancreatic tumor هي dual phase contrast enhanced CT scan with arterial and portal venous phase. The role of imaging طبعا to determine the diagnosis and resectability of the tumor. Ultrasound is highly accurate in differentiating obstructive from non-obstructive causes of jaundice, and with meticulous technique, small pancreatic tumors in the head may be detected. However, negative transabdominal ultrasound does not exclude the presence of pancreatic tumor, nor it is sufficient for staging of the pancreatic cancer. يجي الابيرنس مالتها على شكل hypoechoic mass, وممكن نشوف double duct sign. مثل ما نشوف بهاي الصورة إنه there is hypoechoic mass at the head of the pancreas. This is another image showing a hypoechoic mass at the area of the head of the pancreas with minor vascularity seen. The endoscopic ultrasound is the most sensitive imaging test for the detection of a small pancreatic head tumor, particularly when smaller than 2 cm. These pancreatic head tumors can be missed even with technically excellent CT scan, and therefore negative CT scan in patients with strong suspicion for pancreatic head cancer require additional imaging with endoscopic ultrasound. هنا endoscopic ultrasound image نشوف there is hypoechoic mass obstructing the common bile duct. The CT scan, contrast enhanced multi-detector CT scan with water as an oral contrast agent in the late arterial phase, the pancreatic parenchymal phase, and the portal venous phase. It's currently the mostly widely used technique for the diagnosis and staging of pancreatic cancer. البنكرياتيك كارسينوما عادة تكون خاصة ductal adenocarcinoma تكون hypovascular tumor, and it is best detected in the late arterial phase 35 to 45 seconds. That means when the normal glandular tissue enhance optimally and the hypovascular tumor does not enhance. مثل ما نشوف هنا بهذا الدروينج إنه البنكرياتيك tissue بالlate arterial phase راح يكون أكثر من enhancement of the pancreatic tumor اللي متمثلة بالكيرف الأحمر. تقريبا راح يكون الفرق بيناتهم between الهاونسفيلد unit in the late arterial phase تقريبا 40 هاونسفيلد unit. The typical ductal adenocarcinoma appear as poorly defined mass with extensive surrounding desmoplastic reaction. This mass enhanced poorly compared to the adjacent normal pancreatic tissue and thus appear as a hypodense mass on the arterial face in 75 to 90% of the cases, but might become isodense in the delayed scan. مثل ما نشوف هنا coronary formatted CT image نشوف إنه there is hypodense mass poorly enhancing regarding to the rest of the pancreatic tissue. ممكن أيضا نشوف بالCT double duct sign اللي هي dilatation of the common bile duct and dilatation of the pancreatic duct اللي highly suggest there is a tumor in the pancreatic head. Approximately 10% of cases will be iso-attenuating relative to pancreas in the pancreatic parenchymal late phase and thus extremely difficult to detect. فإذا شفنا double duct sign still highly suspicious for the presence of pancreatic head tumor. Tumors in the head of the pancreas may cause early dilatation of the common bile duct, and the tumors arising in the uncinate process are often quite large, encasing the superior mesenteric artery before the bile duct obstruction occurs. Upstream dilatation of the main pancreatic duct is a frequent finding in pancreatic carcinoma and is often associated with atrophy of the pancreatic tissue surrounding it. مثل ما نشوف إنه there is mass in the pancreatic head with dilatation of the main pancreatic duct and encasing the duodenum. For detection of the pancreatic cancer, الملخص إنه عندنا direct signs بالCT وعندنا indirect signs. The direct signs اللي هي الكلاسيكال hypoattenuating or hypointense mass at contrast in multi-detector CT or MRI. However, 10% of adenocarcinoma are iso-attenuating on CT, and this category of tumor up to 2 cm in size. The indirect signs اللي هي biliary duct dilatation, pancreatic duct dilatation, double duct sign, focal atrophy of the gland due to pancreatic duct obstruction, distortion of the contour of the gland, especially if the mass is large, and loss of pancreatic lobulation, which is subtle but often an early sign. The best diagnostic clue for the diagnosis of the pancreatic ductal adenocarcinoma is poorly marginated mass, hypoenhancing, with abrupt obstruction of the pancreatic duct plus minus the common bile duct, as seen in this image. The most important feature to assess the tumor is local invasion and relationship to the superior mesenteric artery and celiac axis. If the tumor surrounds the vessel by more than 80 by 180 degree of its circumference, then it is T4 disease and it is unresectable. هنا نشوف إنه there is multiple hypodense liver lesion with peripheral enhancement. طبعا liver is always the first site for distant metastasis of pancreatic tumor. هنا an axial contrast enhanced image showing infiltrative mass, hypodense into pancreatic tail. عادة pancreatic tail cancer do not involve vital vasculature and often come to attention later than the pancreatic head cancer due to lack of jaundice and later presentation. Regarding the MRI are particularly helpful in identifying a small group of tumors that are isodense to normal pancreas in CT. The appearance of MRI regarding T1 image, it will be hypointense relative to the normal pancreatic tissue. In T1 fat saturation sequence, it will be hypointense to relative normal pancreatic tissue. In T1 with contrast gadolinium, it shows slower enhancement than the normal pancreatic tissue. Therefore, dynamic injection with fat saturation and arterial face imaging is ideal for the diagnosis. With T2 flare, it's a variable picture. Well, MRCP is very important for detection of duct obstruction, خاصة double duct sign. And also it is very sensitive for detecting of periampullary masses. مثل ما نشوف هنا axial MRI image showing hypointense mass in the head of the pancreas. بالADC طبعا راح تكون عندنا restricted diffusion ودروب بالsignal as shown here. هنا coronal MRCP image showing double duct sign, dilatation of the common bile duct and the pancreatic duct, main pancreatic duct. The differential diagnosis of the pancreatic ductal adenocarcinoma is the pancreatic neuroendocrine tumor. الفرق عنها انه it will appear hypervascular بينما البنكرياتيك ductal adenocarcinoma تكون hypovascular. وايضا pancreatic neuroendocrine tumor there will be no ductal dilatation or parenchymal atrophy and it might show calcification. The other differential diagnosis هو الاوتواميون pancreatitis. بالاوتواميون pancreatitis راح نشوف diffuse enlargement, sausage appearance with no ductal dilatation وعادة ما يكون steroid responsive. بالchronic pancreatitis عادة نشوف diffuse parenchymal atrophy. The duct is dilated, beaded with ductal caliculi might be seen, and the presence of pancreatic calcifications. The other differential هو pancreatic metastasis also appear as hypovascular but usually associated with widespread metastatic disease in another place. الليمفوما تكون عادة homogeneous hypodense mass with no ductal dilatation or any parenchymal atrophy. The other differential هو asymmetry fatty infiltration of the pancreatic host. عادة there will be no mass effect with no duct dilatation and no secondary signs of malignancy. Well, in and out of phase MR is very useful in this state. The group pancreatitis is extremely difficult to be differentiated from ductal adenocarcinoma and it is usually diagnosed retrospectively after surgery. والother differential هو adjacent tumors such as duodenal or GIST tumors. طبعا أهم شيء بالreporting is to differentiate whether this tumor is resectable or irresectable, as overstaging of the tumor will lead to under treatment if laparotomy is not performed. يعني ممكن البيشنت انه ممكن يستفاد اذا سوينا overstaging ممكن يستفاد من السيرجري وبالتالي اذا سوينا overstaging ما راح يسوي له سيرجري والاندرستaging will lead to unnecessary laparotomy خاصة انه الويبل surgery is associated with high mortality and morbidity. الstaging عادة ال T1 tumor it is limited to the pancreas with less than 2 cm. ال T2 tumor limited to the pancreas والsize معناته أكثر من 2 cm. ال T3 tumor beyond the pancreas but not celiac or superior mesenteric artery involvement. with T4 tumor involve the celiac or superior mesenteric artery. حتى نحددها resectable or unresectable. Resectable tumor عادة there will be limited venous invasion اللي هي stage 3 may suggest resectability in a specialized يتعملون ويا الفين resection. Peripancreatic lymph node metastasis, although it is associated with the worst prognosis, however, it does not constitute a definitive contraindication for resection. ممكن نسوي لها resection إذا شفنا peripancreatic lymph node metastasis. Limited any growth into the peripancreatic fat and any growth into the duodenum or the gastroduodenal artery does not also render a tumor unresectable. ممكن نشيلها هاي tumor as the vessel and the duodenum can be resected in a block with the tumor. التيومر تكون عادة unresectable إذا كان أكو arterial involvement of the celiac trunk, hepatic artery or the superior mesenteric artery اللي هي stage 4. Or there will be tumor ingrowth to the stomach, colon, mesocolon, inferior vena cava or aorta. Or there will be hepatic metastasis, peritoneal metastasis or para-aortic lymph node metastasis. Or there will be mesenteric lymph node metastasis that is not immediately adjacent to the pancreas. هنا نشوف في هذا الإيمج إنه there is peritoneal metastasis as shown with the yellow arrows. هاي التيومر is not resectable. هنا نشوف إنه التيومر hypodense mass just touching the vessel. فهذه يعني this patient general will be given the benefit of the doubt and will be scheduled for operation. هنا نشوف إنه there is a mass in the uncinate process and encasing the superior mesenteric artery by more than 180 degree of its circumference. فهاي التيومر is unresectable. هنا نشوف hypodense mass at the confluence of unresectable tumor surrounding the superior mesenteric artery by more than 180 of its circumference. And quite specific signs of venous infiltration is the teardrop deformity. of the superior mesenteric vein or portal vein. لأنه ductal adenocarcinoma is very fibrotic tumor, causing upping the vein and leading to deformity of the venous contour, causing the teardrop sign as seen in this image. بهاي الصورة نشوف إنه there is a tumor thrombus in the superior mesenteric vein, وهاي التيومر طبعا unresectable. هنا نشوف pancreatic carcinoma encasing the hepatic artery, وطبعا هذا التيومر also is unresectable. الأهم شيء بالreporting is to provide information that determines the resectability of the tumor, including the presence of metastatic disease and involvement of the major central mesenteric vasculature, اللي هو portal vein, superior mesenteric vein, celiac, hepatic artery, and the superior mesenteric artery. Dilated pancreatic duct with abrupt cutoff and upstream atrophy, even in the absence of visible mass, should be considered a tumor until proved otherwise, and require further investigation, especially endoscopic ultrasound. هسه خلصنا البنكرياتيك دكتال ادينوكارسينوما. اكو سؤال؟ الو
اكو احد عنده سؤال على البنكرياتيك دكتال كارسينوما؟ ادينوكارسينوما ماكو. كمل السيستيك نيوبلازم دكتور.
تمام. نجي هسه على السيستيك نيوبلازم. السيستيك نيوبلازم عندنا بها 4 main types اللي هي السيرس سيستيك نيوبلازم، الميوسينس سيستيك نيوبلازم and الانترادكتال papillary mucinous neoplasm, solid and pseudo-papillary epithelial neoplasm. السيرس cystic neoplasm هي benign tumor but large tumor that have the tendency to increase in size and causing symptom. Often described as the grandmother tumor due to the its occur in the older women. بيها 2 types نقسمها إلى microcystic and macrocystic. المicrocystic or honeycombed cyst تجي عادة with central scar in 30% of cases and calcification in 18% of cases, while the microcystic type is found in 10% and difficult to be differentiated from pseudocyst and the mucinous cystic neoplasm. عادة it has a lobulated surface with no communication between the cyst and the pancreatic duct. Hypervascular enhancement is sometimes seen and can look as cystic neuroendocrine tumor. مثل ما نشوف هنا انه there is multiple cysts with central scar.
الانهانسمنت اللي يصير يشمل السكار مو السيستيك بارت.
نعم استاذ. The characteristic feature of serous cystic neoplasm is central scar, which is sometimes seen with calcification. Sometimes the microcystic component of the tumor is very difficult to be identified on CT scan. وبهاي الحالة راح يفيدنا ال MRI لأن ال MRI will better identify the internal architecture of the tumor. MRI is also useful in determining the cystic communication with the pancreatic duct or not, to be differentiated from the lesion from a branch duct IPMN. مثل ما نشوف هنا there is a CT image showing a multicystic lesion with central scar. The differential diagnosis of the serous cystic neoplasm هو mucinous cystic pancreatic tumor. هنا تكون fewer in number عادة أقل من 6 with large size more than 2 cm, having cystic component plus minus mural nodularity or calcification in the peripheral wall, and it is also associated with septa. Second differential diagnosis هو intraductal papillary mucinous neoplasm. هنا نفرقها إنه there is communication with the main pancreatic duct. The other differential diagnosis هو pancreatic neuroendocrine tumor. هنا تكون solid serous adenoma, appear as a solid mass, hypervascular and indistinguishable from the neuroendocrine tumors. The best diagnostic clue for the serous cystic neoplasm هو lobulated multicystic mass with central scar and calcification as seen in this image. شوف إنه there is lobulated multicystic lesion with central scar, also visible here and here. The majority of the cases of the serous cystic neoplasm benign with no malignant potential. Even if benign lesion can grow and cause symptoms, pain and obstruction. Lesion measuring more than 4 cm have been shown to grow more quickly than the smaller lesion, and a small percentage, less than 5% of cases, are locally invasive and aggressive, وأقل من 1% malignant and metastatic potential. The treatment asymptomatic small tumor with a classic imaging feature عادة بس تحتاج serial imaging follow-up without surgical excision. The indeterminate lesion without a classic imaging feature هاي تحتاج MRI and or endoscopic ultrasound and complete surgical resection for larger tumor أكثر من 4 cm with mass effect or if the patient has symptoms. هنا نشوف إنه multicystic CT scan axial image. نشوف multicystic lesion with central scar and calcification. هنا طبعا الMR image نشوف شلون طلعت لنا internal architecture of the tumor and septation. This is another example shown here. This is another example axial CT image showing multicystic lesion with central scar and calcification. The other cystic neoplasm of the pancreas هي mucinous cystic neoplasm. هذه تكون pre-malignant tumor that may transform into a mucinous cyst adenocarcinoma in 10 to 40% of the cases. A risk factor for invasive malignancy عادة old age or the lesion size, mural nodularity, thick wall, and patient symptom اللي هي pain and pancreatitis with increased cancer embryonic antigen and cancer antigen 19-9. It is exclusively seen in women, typically in mother woman, the median age مالتها between 40 to 50 years, and it appears as a microcyst with thick wall septation and peripheral calcification. The peripheral calcification is seen in 25% of the cases. This finding allows to make a specific diagnosis of the mucinous cystic neoplasm. The location مالتها عادة تكون يا إما بالtail or the body of the pancreas in 95% of the cases. The base diagnostic clue for the diagnosis of the mucinous cystic neoplasm نشوف large cystic lesion, unilocular or multilocular with encapsulated cystic mass, septation, and thick wall in the pancreatic tail or the body. It's considered as a pre-malignant or frankly malignant because almost all the mucinous cystic neoplasm are resected. True natural history is not completely certain. لأن أغلب الcases يشيلوها by surgery. The overall 5-year survival of the mucinous cystic neoplasm is 95-80% of good prognosis. التريتمنت عادة مثل ما قلنا surgery. هنا نشوف إنه large cystic lesion with peripheral calcification. هنا large multiloculated cystic lesion well capsulated with peripheral solid component. هنا difficult case إنه يعني axial CT scan showing a large simple looking cyst وسووا لها MRI بنفس الوقت هم يعني ما يعني طلعت as a simple cyst بس بالسيرجري التالي انه it found to be that it is a low grade mucinous cystic neoplasm. نشوف انه large multiloculated well capsulated cystic lesion with solid component. This is another example also, a large cystic lesion with solid component. The third entity of the cystic neoplasm of the pancreas is the intraductal papillary mucinous neoplasm. It is a mucin-producing tumor in the main pancreatic duct or the branch ducts. The location عادة مالتها يكون pancreatic head, tail, and the body. بس عادة الhead أكثر نشوفها. It must have a communication with the pancreatic. يعني واحد من أهم الشغلات بالdiagnosis إنه it must have a communication with the pancreatic duct, which is best seen in the MRCP. بها two types. عندنا المين duct intraductal papillary mucinous neoplasm والbranch duct type. هنا التايبس تقسم إلى 4 types. التايب A اللي هو branch duct type. تايب B هو المين duct اللي يجي affecting the whole pancreatic duct, panductal يسموه. التايب C عادة affecting the main pancreatic duct بس يكون segmentary, affect segment of it. التايب دي اللي هو يكون mixed المين affecting the main pancreatic duct and the side branches. The side branch intrapapillary mucinous neoplasm, it has a variable risk of malignancy. 25% contain high-grade dysplasia and 17% contain invasive carcinoma. The best diagnostic clue هو cystic lesion with direct communication with the adjacent main pancreatic duct on contrast enhanced CT scan or MRCP مثل ما نشوف in this image. The main branch intraductal papillary mucinous neoplasm, it has a high risk of malignancy أكثر من the side branch type. 62% contain high-grade dysplasia and 58 contain invasive carcinoma. نشوف dilated main pancreatic duct with bulging papillae and enhancing soft tissue nodularity within the duct lumen. هنا MRCP نشوف إنه there is dilated pancreatic duct with main side with branch side branches intrapapillary mucinous neoplasm. هنا نشوف dilatation of the main pancreatic duct كله. The fourth type of the cystic neoplasm هو solid and pseudopapillary epithelial neoplasm. It is very uncommon neoplasm. عادة نشوفها بالyounger patient 20 to 30 years of old female. It is almost always arise in patient أقل من 35 years of old. It has a solid and cystic component with capsule and early hemangioma-like enhancement and sometimes intratumoral hemorrhage. It has frequently peripheral or central calcification in 45 to 50% of the cases. Presence of the internal hemorrhage, highly characteristic feature, and may result in fluid or hematocrit level. WHO تصنف السبيني tumor as a low-grade malignancy with low malignant potential. مثل ما نشوف إنه there is a tumor in the well-defined tumor in the head of the pancreas with solid and cystic component. The best diagnostic clue is encapsulated solid mass with cystic component and internal hemorrhage عادة يكون in young patient, young women. Now نشوف إنه there is a large well-defined mass having cystic and solid components. هنا for the same patient, the image showing hepatic metastasis. هنا نشوف إنه there is two large masses in a young patient having solid and cystic component. آخر entity بالtumors of the pancreas هي neuroendocrine tumors. The neuroendocrine tumors هي tumors arising in the pancreatic endocrine cells اللي هي islet of Langerhans. عادة تيجي associated with other syndromes مثلا multiple endocrine neoplasia type 1 or خاصة الجاسترينوما or with the von Hippel-Lindau syndrome or neurofibromatosis type 1 or tuberous sclerosis. The location مالتها عادة 85% of the cases arise in the pancreas while 15% of the cases are ectopic in location. Most common ectopic locations ممكن تيجي بالduodenum, stomach, lymph nodes and ovary. أهم شيء بها كإيميجينج إنه well circumscribed mass, hypervascular, but that might show sometimes liver metastasis with hypervascular liver metastasis. نقسمها إلى benign ومالجننت ونقسمها أيضا إلى syndromatic اللي إنه classification معناتها هو syndromatic or non-syndromatic. الابيديميولوجي عادة تأفكت 2 per million. Incidence بالأوتوبسي is high تقريبا 10% بالأوتوبسي نشوفها. It is small benign. التايبس مالتها هي syndromatic. أول شيء الانسولينوما. It is the most common neuroendocrine tumor تقريبا 50% of the cases. It is a small tumor عادة السايز مالتها أقل من 2 cm. 95% occur in the pancreas and 5% ectopic site. 50% of the patient with associated with multiple tumors and have multiple endocrine neoplasia type 1. 10% منها تكون malignant and 10% تكون multiple. الدياجنوستيز مالتها عن طريق الوبوليترايد تكون hypoglycemic symptoms produced by fasting. or blood glucose level less than 50 milligram per deciliter during symptomatic attack, and symptoms relieved by administration of glucose. The other types of the neuroendocrine tumor here, gastronoma, it is the second most common type, 25% of the cases. The other name is Zollinger-Ellison syndrome. 90% occur within the gastronoma triangle. 50% منها يكون malignant and 50% يكون منها multiple. 25% of Zollinger-Ellison syndrome is associated with multiple endocrine neoplasia type 1. The features تكون multiple gastroduodenal ulcer causing abdominal pain, diarrhea, and malabsorption. The gastronoma triangle هذا هو, or known also as the Passara triangle, is an anatomical area in the abdomen from where the majority, 90% of the carcinoma arise. The boundary is superiorly confluence of the cystic and the common bile duct, inferiorly junction of the second and third portion of the duodenum, and medially junction of the neck and the body of the pancreas. The other types of the syndromatic neuroendocrine tumor هي الجلوكانوما, typically occur in the body and the tail of the pancreas. عادة ما تيجي as a large tumor أكثر من 2.5 سنتيمتر, ممكن يوصل السايز مالتها إلى 25 سنتيمتر. الفيتشرز تيجي weight loss, diarrhea, diabetes, necrotizing migratory arrhythmia, glossitis, and stomatitis. 70% have necrolytic migratory arrhythmia, and 50% of the cases have liver secondaries at the time of the diagnosis. The other type هو vasointestinal peptidoma, Vipomas tumor, also known as Vernal Morrison syndrome. Occurs usually in the pancreatic body and tail, تقريبا 75% of the cases, and 50 to 80% undergo malignant transformation. Last type was somatostatinoma, occur predominantly in the pancreatic head or the duodenum at the ampulla of water. The features مالتها تيجي as diabetes, diarrhea, and gallstone. A non-syndromatic neuroendocrine tumor تيجي as hypofunctioning or clinically silent large tumor, larger than the syndromatic tumor at the diagnosis لأنه قليل ما تسوي symptom. The cystic neuroendocrine tumor more likely to be non-insulin producing and non-syndromatic. It has a strong tendency to malignancy more than the syndromatic tumor. هنا نشوف axial CT scan image, نشوف hypervascular mass within the pancreatic body. هنا بالlate arterial phase, هنا بالvenous phase نشوف إنه rapid washout صار بيه لأنه hypervascular mass. هنا نشوف insulinoma as moderately hypervascular lesion بالCT scan, بس بينت أوضح بالMRI as hypointense lesion. هنا contrast enhanced scan, avidly enhancing mass in the head and body of the pancreas. هنا diffuse involvement of the whole pancreas appear as a hypervascular. هنا small hypervascular mass within the head of the pancreas. هنا نفس الماس بس intraoperative ultrasound showing the vascularity of the mass. هنا coronal contrast enhanced CT image show marked fold thickening and wall hyper enhancement of the proximal aspect of the stomach. The more distal stomach demonstrates normal wall thickness. هذا typical of Zollinger-Ellison syndrome. طبعا النيو موداليتيز ممكن يستخدموها بالdiagnosis of neuroendocrine tumor هو somatostatin receptor scintigraphy using somatostatin receptor analog octreotide اللي هو الoctreoscan. Many pancreatic neuroendocrine including non-functional tumors except الانسولينوما express high level of somatostatin receptor. فيستخدمون radio-labeled somatostatin analog octreotide اللي هو 111 indium pentatide, also called octreoscan, can induce uptake in the pancreatic neuroendocrine tumors. A new PET scan tracer, اللي هو 68 gallium dotatate, was recently approved by the FDA, and numerous studies show that it has a greater sensitivity than the octreoscan in detecting small lesion. A combination of PET scan with 68 gallium dotatate and high resolution may be preferred over conventional somatostatin receptor scintigraphy if it is available. وطبعا الاندوسكوبيك ultrasound and the endoscopic contrast enhanced ultrasound is very useful in detection and diagnosis of the small neuroendocrine tumor. Thank you.